Good day, everyone. My name is Venus Mushininga. I'm going to present on the lessons learned from the GICC Observership I did in Ghana. I'm from Zimbabwe and I'm a UICC Technical Fellow. So in my presentation, I'm going to talk about the background of the observership, the methodology, and the findings. Then I'll conclude. Right. The fellowship was conducted as part of my UICC Technical Fellowship from January to February 2023. The title of the Technical Fellowship was Coordination of the Implementation of the CureAll Framework for Childhood Cancer. My host organization in Ghana was the World Child Cancer, and my supervisor was Emmanuel Dogo and Dr. Sharon Kapambwe. So in terms of the background, so Zimbabwe was actually signed up to be one of the countries implementing the CureAll framework through the Global Childhood Cancer Initiative. So I realized then there was a gap that we had no pre-experience of how to do this. But I also knew that there were countries in Africa that had already started implementing the CureAll of the GICC. So there was an opportunity to do a technical fellowship with the Union for International Cancer Control. So then I spoke to Dr. Kapambwe and were able to identify Ghana as one of the countries that was implementing the GICC successfully, that had made progress. So I then applied for the technical fellowship and was awarded to do this learning visit to Ghana. So the purpose of the fellowship was to find out how the coordination structures that Ghana had set up to coordinate the implementation of the CureAll framework and identify challenges and gaps that had been faced by Ghana and the host institution in implementation of the CureAll framework, identify best practices in the implementation of the CureAll framework, and to recommend priorities for coordination coordination of the implementation of the CureAll framework for Zimbabwe from the Ghana visit. So how did was this conducted? So basically what I first did was to do a desk review of the policies, strategies, and guidelines that are in place for childhood cancer in Ghana. And then I conducted structured and unstructured interviews with stakeholders that were identified to be key in the implementation of the CureAll framework through the GICC. So to identify the stakeholders, I got assistance from the World Child Cancer, and then I have observed operations in the Pediatric Oncology Unit at Kolebo Teaching Hospital, and also how World Child Cancer works with stakeholders in implementing, and also there were a number of meetings that I participated in that were set up also by World Child Cancer, and that were already ongoing within the time I was in Ghana. So these are just pictures of some of the interactions I had with stakeholders. They we visited the Ministry of Health, and then we met the LCC team, and then also WHO and CHI. What were the findings of this? So there were enablers that I found from observing what was happening in Ghana. So, for example, there's buy-in from the government on the need to prioritize childhood cancer. There are clear coordination and government structures in place for oncology services that are integrated within the already existing Ministry of Health structures. And then there's structured collaboration and coordination of stakeholders for child cancer. And then multiple partners support child cancer services. And then there are policy frameworks and strategies in place to support the delivery of cancer services. And then there is expertise that is available in country and actually trained in country to work in the space of pediatric oncology. Then there's also a very strong multidisciplinary approach to the provision of cancer services. There were challenges, of course, that the country was facing in terms of implementation. For example, procurement for child medicines and commodities was decentralized to health facilities that are to the treatment centers. So this created, because then they're not able to enjoy the advantages of food procurement, and there's also partial financing of cancer services in the national health insurance. Ghana has made progress in making sure child cancer is funded, and this is there, but they still need to expand the coverage for cancer in the national health insurance. And then there's insufficient awareness about childhood cancer in the community and among healthcare workers who are not working in the cancer space. And there was inadequate infrastructure for provision of cancer services, especially radiotherapy services and diagnostics, and the healthcare workers' incentives and rotation schemes were inadequate. And also there was need to improve the registration of cancers through the cancer registry structures. So there was need to also try and have a hospital-based and population-based component to the cancer registries. And the monitoring and evaluation framework, it wasn't very clear from a visit how it was being implemented. So there's need to strengthen that. And then there's a challenge with accessing quality, affordable cancer medicines on time for the patients. And then there were gaps in dissemination of national childhood cancer strategy, because some stakeholders did not even know that it was in existence and what it covered. There were a lot of best practices that I observed. For example, there's a directive for pathway for children suspected of having cancer. So, for example, a child in a royal center, if they are suspected of having cancer, they just referred straight to the teaching hospitals, which actually allows for early detection of cancer and better outcomes. And cancer specialists are trained in country at specialist training schools that have been set up in Ghana. And actually, in the pediatric oncology unit, to work there, you have to be specialized. And then the teaching hospitals have set up specialist oncology, pediatric oncology units, which allows for better collaboration of multidisciplinary teams within these units. And a shelter is provided for parents and children, including young siblings during the time they're receiving care. And these follow-up systems are in place during and after cancer treatment, and children are followed up for 5 years post-treatment, and sometimes even more. And then the financing models have been put in place within the pediatric oncology unit at Colorado Hospital. There's actually a fund that is set up, they've set up where they actually use funds they get from well-wishers and other partners, which are managed from the pediatric oncology unit, cutting out the bureaucracy. So when patients need medicines or commodities, they can actually access this fund directly, and they can go and buy these medicines when they're not available in the hospital. And then there are various support structures for their families and for the patients as well that are very family centered. We've got palliative care specialists, we've got social services available, and there is also this bidding project which Ghana is implementing, which provides supportive therapy and also capacitates the parents to increase their income. So the children, the whole families can be involved in the bidding. And then children that are admitted in the ward have access to their education. There is actually an arrangement with the Ministry of Education where teachers come in and they teach the school-going children during the time they will be receiving treatment. So this is a picture showing the bidding project, the donations from World Child Cancer, and then we've got the welcome pack. So each child gets a welcome pack when they get admitted to the ward, and there is a meeting. There's actually regular annual meetings where the pediatric oncology unit just discusses the issues they're facing, reward outstanding performers, and then brainstorm on solutions to the challenges that we're facing. Yes, and there is actually a lot of best practices, and I think I would like to conclude that for the Global Childhood Cancer Initiative implementation to be successful in any country, there is need for collaboration and well-structured multi-stakeholder coordination. And political buy-in is critical to enable implementation of childhood oncology interventions, and family-centered approaches fuel success of childhood cancer programs. Thank you so much for listening, and thank you for this opportunity to present. Thank you.